Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day. While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Yep, and welcome once again to the program. We're so glad that you set aside a little time to learn some stuff. And it to me, I'm always amazed when I see somebody out there on the street and around town, how many people actually tune in, whether it's this Saturday or Sunday that you're listening to it, or once a month on a Wednesday. Doc and I get together and we do it on our regular Wednesday program and take calls. We had a bunch of calls last week. And too bad they weren't listening in our studio today because they were on the subject of swelling. And one thing that you will notice that swelling, but as seen by many different practitioners, is not a good thing. What is swelling, and why are we going to talk about a weirder one today? As a matter of fact, today the doc said our topic, believe it or not, was going to be another cause for the, quote, swollen leg. I used to think before I became your patient that was my middle name. What's your leg all swollen for? Aren't there a lot of reasons that you can get a swollen leg? And how do you get through them all to determine what guy you need to see and what can be done to help you?
Yeah, what kind of doctor is going to give you assistance with that is the bottom line. But there's a lot of different reasons why people might have swelling in the legs. Now, I will say that in general, the most common single cause for swelling in the legs is venous disease. But it can be related to heart problems or metabolic abnormalities, kidney problems, liver disease, all sorts of things. Some medications, some medications will lead to swelling of the legs. So, there's a number of different things. And, swelling is one of those things that brings a lot of patients into our office. Again, it makes sense because venous disease is one of the more common reasons why people might develop swelling. But so our job is when somebody comes in with a primary complaint of swollen legs, then we have to figure out, what it's all about.
The thing that really amazes me, gang, if you've ever seen an anatomy book, or like if you're in Doc's office and you see these cutaways, there's a lot of traffic going on in that area of your body. Yeah. These legs, there are so many different systems that are all meshed in with each other. It must take a real Sherlock Holmes and Dr. Watson approach to sort of narrow down, eliminate the things that aren't caused in it, and then get down to maybe one or two that you now can handle to experiment with. Am I right?
Yeah. There is a lot going on anatomically, physiologically in our legs, and there's some bleed over from one problem to the other with respect to the symptoms. Somebody comes in with pain. Well, pain might be due to just about anything that's happening in the leg. But we have to be a little bit of a Sherlock Holmes and figure it out. But swelling is one of those things that is a classification status. There's a classification system that we use for venous disease, and swelling, which is the third level of clinical classification, is right in the middle. The 1 and 2, 0, 1 and 2 are a lot less complicated, fairly straightforward. 4, 5, 6 is also very complicated, but swelling is what we call C3 in venous vernacular, and swelling is kind of I look at it as kind of a bridge with respect to venous disease. It's kind of a bridge. Like I said, those things lower clinical status are pretty straightforward, easy to treat and to handle. Then you have swelling C3. Those above are a little more complicated. So it's kind of a bridge from simple to complicated. And when we see swelling, we get excited about it and want to do something about it so that that patient doesn't get worse with time.
Yeah, and I got two questions. I'm sure these come up all the time. Number one, I'm guessing that swelling just doesn't happen for no reason. Right. You know, but then there's a lot of things that cause swelling that are kind of small things. Like if you notice, if you're not a person that stands up all day, and for some reason you're helping a guy paint a boat or a house, and you're standing up all day, and you get home at night and your legs are swollen. Hey, what's up with this? So there's some things that trigger it pretty much automatically. Yeah. But I'm guessing is that whenever there is swelling, and the discomfort that accompanies it, that must mean that something has to be done here. Otherwise, will it go away on its own?
Yeah. Well, that's a good point. If somebody has swelling, or if they notice that they have swelling periodically or in specific situations, but it doesn't last very long. But, for instance, what you just mentioned, somebody's on their feet all day long, they get a little bit of swelling. Well, probably that doesn't indicate a major problem. But if it's slowly getting worse with time, then it's probably something that needs to be looked into.
Sure.
A lot of people will also say, gee, I ate a lot of salty food over the weekend and now I feel a little swollen. Well, a little bit of that is probably within normal limits. But again, if that type of observation in any one particular person is getting more consistent and worse with time, then probably there is something going on. So, typically, if somebody has swelling in the legs, usually it's due to something. Yes.
Yeah, and by the way, gang, some of you try to rationalize it out. Before I met Doc and found out what was on with me, when somebody said, gee, your legs are swollen and they're all red. I said, I've been standing up all day and they're sunburned.
Yeah, right.
It had nothing to do with standing up all day or being sunburned. It was an ongoing condition that you treated for, and I know that some of that's going to come up in our discussion today.
Yeah. So so venous insufficiency, like I said, is one of those reasons why people might have swelling. And just quickly, we've talked about this before, but what is it about venous insufficiency that leads to swelling? And veins are the blood vessels that carry blood back to the heart. So veins in our legs should be carrying blood upward consistently on its way back to the heart, and sometimes they fail in their function and the blood starts to go in the wrong direction. So if somebody develops venous insufficiency, then the blood is actually, settling downward into the lower leg, and as you might imagine, between the blood settling down and also the increase in pressure in the venous system, that can lead to fluid, moving out of the vascular space, what we call the vascular space, and moving into the soft tissues.
Yeah, and that's a question too. And it seems that, we talked about this before, how much blood you have. And so the swelling is not your blood. I mean, I'm sure it's part of it. But isn't there an awful lot of stuff that will, in concert with swelling, say, okay, I'm going to do this too. So there's all these things going on in there, and they're all contributing to medium, larger, and then huge swelling.
And you're right. It's not like blood is leaking out of the veins. No, typically it's clearish, plasma, fluid, and molecules, and et cetera. But it's not like blood is leaking, from blood vessels into soft tissue. But so why does that happen? Well, that happens because there are many, many one-way valves within veins that are very, very important in moving blood upward. And those valves can fail. Usually it's genetic. The thing that we inherit from parents and grandparents is the propensity for these valves to fail if they had venous disease, and they're gifting that upon you in the next generation. Then typically it's those valves that are failing, and then the blood starts to go in the wrong direction. So as the blood goes in the wrong direction, it leads to pooling, and that can, as I mentioned, lead to swelling. And like I said, venous insufficiency is the most likely reason. Luckily, we have easy procedures that we do to eliminate the insufficiency and the reflux. And hopefully, if that's all it is, then we can treat that swelling pretty quickly and fairly completely.
I've had the opportunity in the last couple of months to talk to staffers with your staff when I've been in the office, and it's interesting to me because many of us for this COVID-19 have been sequestered at home. And
Right.
I'm guessing that a lot more grandkids and kids are telling mom or dad or grandma or grandpa, hey, what's that funny blue thing on your leg? Because, all of a sudden, grandma's sitting around in shorts. They never see grandma in shorts.
Right.
But now they do. And the fact of the matter is, from what I understand, is some of the elective procedures have not been performed over the last few months just because cosmetic stuff is just not a priority right now.
Right.
But I'm wondering if more people have come to be in touch with the reality that they do have issues and are now figuring, one of the benefits from being home is I'm going to get healthier. I'm going to get my legs fixed.
Yeah, there's the two things that are happening there. Number one, they're at home and they're not distracted by work and other things. And so I think people are taking note of symptoms that they might be having. So when they recognize it, then they think about coming in to see us. Or there are people who are not working, and if they have an appropriate type of problem that is medically necessary for us to do the procedures that we do, then they're taking this time.
Sure.
Since they're not obligated to in other areas, work or family or whatever, to catch up on health issues.
And one of the ladies, it's a patient of Dr. Julif's, told me that while she stood up for a living, she's in the sales business in a jewelry store. So she's on her feet all day and has been home for a few months when all the malls were closed and sitting down most a lot. And her legs got just as swollen at home as they did at work.
Yeah.
So it's I guess upright or partially upright, but those legs are still dangling down there.
Right.
If you've got venous insufficiency, that blood's not coming up, is it?
Right, right. And that's another good point. Somebody like that, they may be just contributing the swelling to being at work.
Yeah.
And now all of a sudden they're not at work, but they're still getting the swelling.
Yeah.
So they're saying, gee, what's going on here? So anyway, another cause for swelling that we see also quite often is called lymphedema, and that's something that we've talked about before. But lymphedema has to do with fluid moving through something that we call lymph channels or lymph vessels, and
are they mixed right in with the veins? In the same area?
They do. They're in the same area. They often run in the same kind of spaces. And most people know about arteries and veins. Arteries are the blood vessels that carry blood from the heart. Veins that carry blood back to the heart. But not a lot of people have heard about lymph channels and lymphedema, but they're in the same system as lymph nodes. I think a lot of people have heard of lymph nodes, and lymph nodes are a lot of people refer to them as glands,
indicator,
because
get swollen.
When we get sick, they get swollen. And we've got them in the neck and in the armpit and in our groins and actually throughout our entire body. But there's tiny little lymph channels which are very very much smaller than arteries and veins. Some of them are just one cell thick, the lining.
Wow.
And so those tiny little lymph channels are in charge of moving fluid around our body. Our body is 70% water. So, in the water is, moving from one place to the other all the time. And again, the lymphatic system is in charge of, collecting that fluid and moving it back to where it should go.
You know what I love about Doc? He explains this stuff. It's like, yeah, I get it. It takes me a while, but I do get it after a while. And what I think is amazing when you talk about that is that the amount of this water. And remember you told me last time, and we found out how fast does blood make it through your system. It's like there are miles of these channels and veins and things in your body. It's amazing. Truly amazing.
Yeah.
Nice piece of work.
Yeah. Oh, yeah. Yeah. It's a great machine, the human body. So blood goes from arteries, and then it moves into something that we call arterioles, which is just very, very small arteries, and then it goes into the capillary system. And the capillary system are the smallest of blood vessels, and capillaries are those blood vessels, those tiny, tiny blood vessels that connect the arterial system with the venous system. So blood comes down through the arteries, makes it to capillary beds, to basically all the tissues of our body, and the red blood cells are letting go of oxygen because the tissues need oxygen, and then then it gets shunted into the venous system. Well, those capillaries have a certain amount of leakiness to them. And that's where the fluid is again moving out from the vascular space to the soft tissue of the body, so that's where the fluid then needs to be handled with respect to getting it back again to where it needs to go. We refer to that as the interstitium of the body, and we call that fluid interstitial fluid. Well, what is that interstitial fluid? Well, really, it's just water, for lack of a better term, with molecules.
I was going to say little molecules in it, right?
Yeah, proteins and then things like what we call cellular debris. And the cells are always kind of breaking down, and they turn into little particles that have to be transported, moved, and filtered by lymph nodes, etc. It's a fascinating system, and one that people usually don't think about, but it becomes very, very important as it pertains to another cause for swelling. So where do we have lymph nodes? Well, we have lymph nodes, like I mentioned, in the neck and armpits, groins, but throughout the middle of our body too. Where and again, like you mentioned before, the lymphatic system sort of follows arteries and veins, and it moves fluid upward if it's in the legs, getting filtered by lymph nodes, and ultimately it moves into what we call the thoracic duct, and that's the largest lymphatic vessel that goes up the middle of the body.
So that's a pretty good sized pipe.
Yeah.
In comparison to the rest of them.
That's something you could see, when you're operating on people, you're going to actually see the thoracic duct. And, these other lymphatic channels, sometimes you don't even see them when you're doing surgical procedures, et cetera.
Incidentally, gang, that's the part that I get fascinated about. And one of my biggest takeaways for an earlier show with Dr. Juleff. And by the way, you can see a lot more of what Dr. Juleff is up to. And please visit the website, veinclinicsofhawaii.com, veinclinicsofhawaii.com. Some of these things we're talking about are in graphic there. I mean, you really learn an awful lot. But what I'm constantly amazed at is that the artery starts pretty big at your heart. It's a pretty big pipe, goes all the way down, and as it gets further and further down, it becomes smaller, and then it's done. And that stuff's got to get now from where the arteries were. It's got to get over the veins, and those are really small too. So it seems the heavy lifting is done by the smallest vessels because they're really busy because they got a lot of work to do in a short period of time.
Yeah. Right. There's a lot of activity down there. So anyway, to give you an idea about the amount of fluid that's being transported through the lymphatic system, again, is the amount of lymph fluid moving through this thoracic duct, which is the main lymphatic vessel in the middle of our body. It'll transport about 4 liters of fluid over the course of a day. So 4 liters, 1 liter is a little over a quart.
Nearly a gallon.
So basically a little more than a gallon of fluid.
Yeah.
So that accounts for quite a bit of fluid. So what is lymphedema? Well, lymphedema is basically when that entire lymphatic system is not working well for one reason or another. The fluid is not moving upward, and we can get swelling in the legs. Essentially, that's the area that we're talking about.
Yeah, in other words, I'm getting it there. That's where we're happening here today, gang. Dr. Juleff wanted to talk about this and some other terms that we don't know about yet. You're going to learn in a minute. But the interesting thing is that I'm imagining, and when a lot of people think when they got a big cut, that it's just blood. it seems to me that what you're saying, no, wait a minute. There's a lot of systems going on in there.
Sure.
When you cut them, you cut one, you're cutting a bunch of them.
Yeah.
So you have lymph stuff, you have plasma, you have white blood, you have other stuff leaking out of there. Yeah.
Exactly.
Gee whiz.
Yeah. A lot of different components and a lot of reactivity and reactivity with respect to the blood vessels in the lymphatic channels that you're disrupting when something like that happens. But so when does lymphedema occur? What are those things that can disrupt the lymphatic system? Well, things like cancer, trauma, having surgery. Sometimes just having surgery is going to, disrupt lymphatic flow and it can result in swelling. Obesity is a very common thing that can lead to lymphedema as well as other problems with respect to swelling. But and then there are kind of genetic factors. But with respect to the kind of work that we do, we have found that lymphedema and venous insufficiency very much go hand in hand. So in people that have developed, for instance, venous insufficiency because of an inherited trait or whatever, if the longer they have that venous insufficiency ongoing, the more likely they are to develop a component of also lymphedema. So in many patients, we are trying to deal with swelling, not only with respect to their venous insufficiency, but also this thing that we call lymphedema.
Yeah, and gang, I want to tell you, this is really an important juncture because there's been such a dramatic paradigm shift in the way these things are diagnosed and treated in doctor profession. That if you had mom or grandpa back in the day that had vein stripping and you haven't had your veins looked at because you remember what a miserable time they had, things are a lot changed. And I'm imagining, that there's been a lot of artery work done. There's been a lot of, vein work done. But I would imagine now that we're getting more sophisticated with our diagnosing and equipping and stuff, that these even smaller systems can somehow be surgically corrected as well. Do you ever perform some of that in part of what you're doing with, say, a vascular condition?
Yeah. Unfortunately, no. Are there experimental type of procedures that are being done and evaluated and studied, et cetera, for lymphedema? Yeah, there are. It's not those procedures are not widespread accomplished throughout the country.
Oh shucks! But I'm the further to guess to that would be there's no way we can get in there and snip it and fix it. Yeah. And there's no pill you can take. However, what contributed to this condition was you not having a really good lifestyle of some kind.
Yeah,
and
sometimes
you can do some things. At least identify why that leg was swollen. Yeah, it's not my veins today; it's my lymph nodes because I did this or I did that.
Yeah, well, and it's not like we don't, even though we don't have easy, surgical procedures, minimally invasive surgical type procedures to do for lymphedema the way that we do for venous insufficiency. There are still things that we do, and for the most part, we can treat people with lymphedema and venous insufficiency, and at least make things quite a bit better than typically what they're like when they come in, and hopefully try to get them to a state that is as normal as we possibly can. And basically the bottom line is to improve quality of life, and I think most of the time we can do that.
Yeah, and that, gang, that's the reason we gather. It's improving the quality of life. I mean, there are a lot of things that Doc's done over the years, and a lot of vein places do, cosmetic stuff, and you look great, and it's wonderful, and if you need it, and a lot of us do for self-esteem and other reasons, but really it's the quality of life, especially that you've said so many times, Dr. Juliff, that this is a condition that sneaks up on you over decades, and it can be the most disturbing to your lifestyle when you're older. When you can enjoy the fruits of your labor and travel and do all the things you want to do, but Harry can't come because his legs are swollen.
Yeah,
don't
definitely.
be Harry. Don't be Harry. Let's get something done here.
Right. Yeah. So, and then I mentioned before the other causes for swelling: heart disease, kidney disease, and some medication and metabolic abnormalities, etc. But then there are some more unusual causes for the swollen leg, and that's what I wanted to talk about today.
And wait. Here's where I get to say, oh, really? Surprised, because I know, see, Doc sends me, and I knew that we were getting into case studies.
Yeah.
And I want to tell you right now, everybody, it's not on purpose, but it's about a 50-50 deal. We talk about women, we talk about men. Today, I noticed on this particular example is a 55-year-old guy, a 54-year-old male.
Yeah.
And I can't wait to hear his story, because that's going to make a lot of other males that are out there listening thinking, Mom, why are you making me listen to the Vein Show?
Yeah.
It's the Veins is a female problem.
Right. No.
It's an equal opportunity problem.
It is. Yeah, it is. It's coincidental that we have a patient. But, this topic kind of came up because we treated this patient here recently. Mid-50-year-old guy. And no prior history of lower extremity evaluation or treatment. He hadn't been treated for vein disease or anything else in the past. He had a history of high blood pressure, but otherwise he was relatively healthy, except for the fact that he was morbidly obese.
Thanks for dropping that in on us, because that was one of the titles that I was able to shirk years ago. And now when I talk to people, and I've seen a lot more people since this COVID deal's been around, because we're not going to work for 8 hours. We're out, Anyway, there's an awful lot of it that I think is really interesting, and how quickly you can undo those bad habits. And a lot of people are doing that right now because they're staying at home. They're not snacking as much. When they go to the grocery store, they're saying, I don't really want to buy these cookies. I'm going to buy fruit. I think some of us are getting healthier.
Yeah.
That's good.
Well, that's a good thing.
Yeah, you bet.
That's a good thing. So he's 5'10", and he weighs 405 pounds. So he's got a BMI, a body mass index, which is one of the things that we look at with respect to weight. But he's got a BMI of 58. Normal is around 25. Mm-hmm. So this guy unfortunately was very, very heavy. And he had been a big guy basically all of his life. From the time that he was a kid. But as he went on, as he was getting older, he noticed that his legs were disproportionately getting bigger and bigger. So this kind of continued for a number of years, and he noticed that the additional, girth, additional what he referred to as swelling, was not only in the buttock and leg, but it went down through the entire leg down to the ankle. So by the time he was in his 40s, he had a fairly large overhang of skin and fat on the inner side of his thigh, which was hanging, kind of over the knee, which is that's kind of a typical appearance for, the topic that we're talking about. So it was distressing.
Okay, let me tell you, gang, I was short of that. I mean, I had other issues, but I want to tell you that I became really aware of it. I don't want to say painfully aware of it, but very aware of it being in the doc's office, because everybody comes there and everybody's there. You don't say there, how you doing? What are you doing? Are you okay? How's everything? No, because they're the doctors. They got something going on. And it's amazing what people will share once they know they're in an environment where they're not bad. And that's one thing I must tell you about Dr. Juliff's staff. I don't care how bad your situation is. They're so professional. You're treated with respect. You're treated with care. And I think that's that in many, you're not a vein surgery factory. There are many places that this experience is just plain not available, and that speaks highly of all your people.
Yeah, well, I'm very proud of my staff. They are like that. They're every one of them is very caring and very and concerned. I think that's a good word.
Yeah.
They are concerned.
So this guy, knock on wood that he got to you when he did, because there's any number of things that could go very wrong with this guy very quickly.
Mm-hmm. Yeah. So as time went on, his legs were getting bigger and bigger, and became tremendously impacting his quality of life and what he could do and how he could mobilize and where he could travel to and all those sorts of things. But he noticed that, and this is one of the things that he mentioned when he first came in, and this is sort of key again for the disease process that we're talking about, is that even though his legs, from the waist down, he was getting bigger and bigger, his feet always looked relatively normal. And as he got bigger and became more and more inactive, his weight went up, and that just kind of compounds the whole thing. So he first discussed it, a number of years prior to coming in to see us with his primary care physician, and his physician put him on a weight loss program, which he felt like he adhered to, relatively well. And he may have lost a few pounds, but didn't really see much of an effect or much of a result in the size of his legs. His legs just kept getting bigger and bigger. So his PCP had no other good ideas for him other than diet and activity. So he just kind of, went on living his life with the inconvenience of, these huge legs that he was kind of at a loss to know what to do with,
Yeah, and let me tell you, gang, because I don't think I ever got as critically needing attention as this guy did or is. We'll find out about the treatment in a minute. But I can tell you that it almost is like a miracle when every day, instead of saying, well, I'm going to go to the store today, but I'm only going to go once a week because it's just humbug to park and walk and I get tired. And now I go every day and without a car, because when you can, you can. And I'm guessing at the light at the end of this tunnel for this guy is that little by, he was getting his life back after he started to get treatment.
Yeah. Well,
we'll talk about that.
We'll talk about that. Actually, we just treated this guy not too long ago, so hopefully
it's a work in progress.
That's what we're working toward. But at some point, I think somebody must have recommended that he use compression stockings, which was a good recommendation. Because in these people, typically we do put them in compression stockings, but he didn't feel like it helped that much. And again, he just kind of kept putting on weight. Well, about a year before he came to see us, he started to see discoloration of the skin in the lower calf, and very similar to what we see in venous insufficiency.
Sure.
With people that are developing what we call skin changes. Happens
just like leather. Yeah,
right. But it starts at first with a little bit of discoloration, brownish discoloration of the lower leg, and that just gets worse with time. And as you mentioned, as time goes on, that skin becomes more and more thickened, and rough and leathery, and that's the area. That's then the situation where we see skin breakdown and chronic ulceration. So eventually he did develop an ulcer in the area of the left ankle, and began treatment at a wound care center. And he was making a little bit of progress with the wound care people, and eventually it will heal. I think with local care and some of the things that hopefully we'll be able to do for him. But so that is really what brought him in to see us, was that ulcer. The wound care clinic had referred him to us, and for us to kind of help in the further evaluation, and to see if there was anything that we could do to help this guy.
Yeah, and gang, that's one of the reasons why, number one, we do the show, and you can check out more at veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. Is that as what Doc was just talking about, when it gets to that point, and I know, Doc, you've explained, I've been just flabbergasted myself, because I know I had an ulcer that I was actively treating for a couple of months before I figured out, hey, this isn't really changing.
Yeah.
And what you said is I was relatively a short timer, because there's some people that just get in a habit of buying that box of Band-Aids a week because that's what they need for that hole.
Yeah, many people will treat an ulcer that's not healing very well for months and even years.
Yeah,
that's not an uncommon scenario.
But this guy, because he noticed the discoloration, probably he already knew about the size. So was that a signal, or was it the hole itself? Or both?
Well, I think it was probably the ulcer. Yeah, that finally that then led him to a wound care clinic that was then helping him with local treatment to the ulcer. And again, they were making progress. The ulcer was slowly getting smaller, but the wound care clinic referred him to us because there are things that we can do.
Olafort, that's where I got to come in here, because I think this is the important part. As Doc said, when I was a kid, there was no such thing as a wound care center.
Yeah.
You went to the ER, you went to your doctor. The ER stitched you up, the docs took him out a week later. But in the meantime, I'm thinking that these folks are professional, all these guys and gals that you deal with. And so they are way more likely than in days of past to say, this is a venous ulcer, you need to see our vein guy.
Yeah.
Because we can put this silver stuff on you for 6 months. It's just going to come back. It's not going to heal. To get this healed, you need to be treated.
Right.
Wow.
Well, that is a very good point.
Yeah,
yes. We work very closely with the wound care centers that we're associated with, and actually most leg ulcers of people that are going to wound care centers, 70% of those are due to venous stasis
70%.
problems.
That's
So
a lot.
the vast majority are due to venous insufficiency, and so that's why we encourage people, if they have an ulcer or if they have a wound that's being treated and that just doesn't seem to be healing, and maybe they haven't had their vasculature, their circulation looked at, then by all means they need to come in and see us, because the things that we treat are definitely the key to not only getting the ulcer healed but also keeping it healed, because the recurrence of venous ulcers can be very, very high if you don't treat the entire person.
Is this guy at an important threshold right now?
Mm-hmm. Yeah, he is.
Yeah.
Because he's got this ulcer,
Yeah.
and I'm sure that it would not have healed on its own.
Sure.
That can lead to other complications. And do people potentially lose extremities from chronic ulceration and infection and osteomyelitis and all this sort of stuff?
All that
sure,
stuff, yeah.
Absolutely. So
Okay, well, knock on wood, we want to put this guy down on the success roll one of these days.
Yeah,
not too far from now. We hope.
Not too far. Yeah. So anyway, he came in, and so we did our usual evaluation. We took a history and did our physical examination, with this patient, as with other types of patients with him, the physical examination is really kind of the key, because of the signs that we see in people with this condition. He had very typical findings. He had a very large leg, something that we call a stovepipe type of appearance to his leg. His foot was spared, and he had enlargement of the leg that was not typical of other things, like swelling from venous disease or swelling from lymphedema, etc. But we did find that he had venous reflux, which is often the case. Again, the venous insufficiency, lymphedema, and what this patient had, and we're going to talk about it in just 1 second, but he has something called lipedema.
Lipedema. Oh, boy.
And so lipedema also kind of is in that category.
By the way, obviously not necessarily connected to the lips.
No. Yeah, that's a whole different thing.
Oh, darn. Okay.
Lipedema, there's kind of gray areas of lymphedema, and venous insufficiency. There might be components of each, a
little overlap.
A fair amount of overlap. So we found that he had some venous insufficiency, because of his obesity. I'm sure he has some component of lymphedema, so we'll be addressing that. And then in addition to lipedema. So we fixed his venous insufficiency, and we instituted our usual protocol for the lymphedema part of it. And then we'll kind of be seeing how he progresses from there, especially as it pertains to this venous ulcer. But there are other things that can be done, which we'll touch on in a minute. In a minute, but yeah, so he has something called lipedema. When we say edema, edema means swelling of one sort or another. And even though lipedema is not in and of itself fluid, although there is some component of fluid accumulation, but there is mainly other things going on. We still refer to that as edema because it's enlargement of an extremity. But what's happening in lipedema is it's really a problem with fat storage, basically. The fat cells within our body, they actually increase in number and in size as they accumulate more, lipid molecules.
Gotta go somewhere.
Yeah. And we call those fat cells adipocytes. And again, these adipocytes in people with lipedema are increasing and filling up, and it's developing an overabundance. So, unlike the other forms of edema, lipedema is seen mostly in women. Vast majority in women. So it's a little unusual. Actually, our patient is a little bit on the unusual side because I think it's about 90% of people with lipedema are women. Unfortunately, this guy had it. Why does it occur primarily in women? Well, it's thought to be thought to have some hormonal basis. The etiology is probably related to hormonal changes because we often see it occurring, and the process starts at periods of a woman's life when they are hormonally active and changing. Times like puberty, pregnancy, menopause, that type of thing. There can also be some component of stress. And also plus minus, surgery. Yeah. So, surgical procedures are a stress in and of itself. So those are the times that we actually see kind of the initiation of this whole process in a woman. Genetics probably plays a role too. We see a greater abundance of lipedema in people in families. So again, there's probably a genetic component. Typically, these people bruise very easily, and the affected areas of their body can be tender to the touch. So, in those areas where they're accumulating a huge amount of fat tissue, it can be tender. So that's one of the primary symptoms that these people have. So not only are they dealing with the huge nature of their body habitus, it's also uncomfortable because it's painful. They bruise easily and that kind of thing.
Okay, gang, I know we're kind of moving fast, and we try to cover as much ground as possible on these times that we get to spend with Dr. Julep on the radio. But if you want to know more about these things, you can click through to a lot of it on the website, and that's. Most of us are now communicating with Doc on the web, and everything can be set up, everything can be done there. That's socially distanced in great practice. When it comes time to a procedure, equally as professional. But please visit veinclinicsofhawaii.com for more. veinclinicsofhawaii.com.
Yeah, so the hallmark here, one of the hallmarks of lipedema is that often the trunk of the patient is relatively normal. So this really is a process in most people from the waist down. So again, this fat accumulation occurs mainly in the buttocks and the hips and the legs, from the groin on down. So there's this disproportionate appearance, that's kind of one of the hallmarks. Another hallmark is something that we mentioned before, and that is that the feet are usually normal in size, in appearance, in the patient with lipedema, as opposed to patients with either swelling from venous insufficiency or swelling from lymphedema. So that again is another hallmark. The feet look completely normal. In the advanced stages of lipedema, the fat layer of the lower leg can actually kind of drape down over a relatively normal-looking ankle and foot. And again, I mean, when you see this, it's just it's so striking that again, the clinical diagnosis is very easily made by just looking at these people most of the time. We use the term column leg or stovepipe leg, and that just means that the leg doesn't have the normal shape that you would normally see in a person of normal weight. And it's just kind of the diameter of the leg is the same from their upper thigh to down to their calf. There's something that we call Stemmer's sign with respect to physical examination, and that is when you try to pinch the skin on the top of the foot in the area of the second toe. This is a fairly specific physical finding.
There's a little secret you're learning here, folks.
Yeah, and so if you can pinch that, and if you can pinch the skin, then that's negative. And we see a negative Stemmer sign in lipedema as opposed to lymphedema, where in lymphedema the foot is swollen and you can't pinch the skin. So that's one of the things that we often do to differentiate the two. So what is the cause of lipedema? Unfortunately, we don't really know, other than the fact that, there's probably a genetic component. There's probably a hormonal component, but what exactly is it that incites, this fat deposition problem in people has not been completely defined. And again, there's some interrelation with lymphedema, but again, that hasn't been completely spelled out either. Is there a cure? Unfortunately not. There's not a cure. So for most of these people, we try to optimize the situation that they're dealing with. We try to do whatever we can to optimize their quality of life, and in most cases we can make things tolerable.
Yeah, and gang, don't be discouraged by saying that there's no cure, because this is a disease that comes on over a long period of time for most of us. And the quality of life is the part that we're really talking about here. So what we really want to do is identify, what is that? I mean, there's some treatments, there's some ointments, there's some compression, there's some things that you can do, there's some exercise, there's a lot of things. Don't just say, well, woe is me. I got a hole in my leg and I'm not going anywhere forever.
Right, right, exactly. Yeah, as are many things. Our ability to improve our patient's quality of life has to be dependent on the patient's, interaction and, commitment to making it happen also.
And look at all of the neat tools and toys and things that have been developed that make these things a lot easier than they used to be. I mean, and right now, a real quick mention maybe, because everybody's wrapped up in this COVID-19 and everybody knows that some people are spending an awful lot of time in bed. I know there's circulation problems, with that. And I would imagine the more moving around you can do, particularly if you get rid of some of these other conditions, the less likely you are to be getting something even more serious while you're in the hospital.
Oh yeah, absolutely. So, what is the frequency of lipedema? Actually, it's a little more common than you would probably think. Because it affects about 11% of women worldwide. So, 1 out of 9 women has some component of this thing that we call lipedema.
Wow, that's a lot.
It is a lot. Yeah. And luckily, most of them are, maintain a status that, you might say, well, that person is a little heavy or whatever, but it doesn't get to the extreme, levels, for instance, of the type that we see in the patient that we described before. But some component of lipedema is seen in an awful lot of women, 11%. What are the complications of lipedema? Well, cellulitis, which is, an infection of the skin.
Itis infection.
Yeah. And, with same sort of thing that we see sometimes in, lymphedema and in chronic venous insufficiency, but, infections can arise. And then also, like we touched on before, with time, if the lipedema isn't handled, in a way that is going to optimize the condition, it will lead to the skin changes that we typically see in venous insufficiency.
Let me ask you on that, because I do know that I grapple with that a while. I still have it, and I guess it takes a lot longer to come on. And do you find that a lot of patients didn't really see it because it was slowly?
Yeah.
And then somebody else would see it. Hey, how come your leg's all red or black or blue or whatever color it got?
Right. Yeah. All of these things, unfortunately, come on very, very slowly. And, because of that, people tend to, people find it easy to ignore those signs. And people end up living with it. They just kind of accommodate their lifestyle. Like our patient, these skin changes can lead to what we would refer to, a higher level advanced kind of things, and ultimately lead to chronic ulceration, which again makes it even a little more, morbid with respect to, potential complications. So how do we diagnose it? Again, it's primarily a clinical diagnosis, and luckily that, the signs are such that when people come in and we examine them, it's pretty obvious, what's going on. There aren't really any, specific blood tests that we do. But luckily we don't need it. And again, there's usually not really a radiologic, X-ray or anything.
I just woke up on that and said, so it's not going to hear. You're not going to hear it at your office or any other doctor. Okay, doc, I got it. It's this.
Yeah.
Because this seems to me, it's what really diagnoses this is experience.
Mm-hmm. Yeah.
With as many decades and as many legs and as many swollen stuff that you've seen, and you pass that down to staff, it becomes something that I would imagine would be on a checklist. Check for this, check for that, because it's indicated that this person might have, in addition to this, and that.
Yeah. Yeah, and part of that also is just making sure that they don't have other things. For instance, one of our jobs is to figure out whether they have venous disease. So we'll be looking into that. And there are other things that we can do to diagnose lymphedema. Is lymphedema part of the picture? It's not only a matter of doing things that are going to pinpoint the diagnosis, but also doing things that are going to eliminate other reasons.
Yeah, and by the way, one of the things that I saw in the notes that you got me was liposuction. And I do know that a lot of times people thought liposuction strictly a cosmetic thing.
Yeah.
It's got nothing to do with medicine. However, I guess that there are certainly instances where that's not true, where liposuction can provide relief, but does it provide a cure?
No, unfortunately it doesn't. But liposuction is one of the things that we can do for lipedema, in addition to a number of other things. But usually those are people that have fairly advanced stages. Like our patient. I mean, our patient may be a candidate for liposuction. Unfortunately, it doesn't cure it. We can make it a little better. We can sort of optimize the status and hopefully improve the quality of life as much as we possibly can. But, unfortunately, there aren't any medications that people can take that are going to, dissolve fat and get rid of it.
As many people make claims for that.
Yeah.
But you see a few disclaimers after, too.
Right. But increasing exercise and, dieting to the extent that you can is never a bad thing.
Sure.
Dieting in general doesn't work to get rid of the fat that is part of this, abnormal fat deposition process that we see in lipedema. But I think dieting to minimize the obesity that many of these patients otherwise have is probably a good thing. And activity and just trying to maintain as healthy a lifestyle as you possibly can is a good thing. It's never a bad thing. That's for sure.
Isn't it true that sometimes a procedure or a treatment that you recommend will kickstart somebody into taking more responsibility? In other words, I do know that you said, I've heard you say this and others many, liposuction is a real tool, but it's just temporary because your body created those extra fatty things because it needed them, because of your habits. If
Yep.
your habits stay, they're going to make some more. But it's a heck of a big start when all of a sudden, you see, that looks pretty good. Okay, well, stay away from the chocolate. It's going to look even better.
Yeah.
Or whatever, or whatever their stuff of choice is.
Right. Sure. So there are some of the other things that we can do is, even though, this is a fat deposition problem, there is, excess fluid usually. So we institute some of the things that we normally do for lymphedema, which is to, use compression stockings and elevation. There are massage opportunities, something that we call decongestive therapy that can be utilized. And again, we try to do anything that we can to minimize the process and to optimize, the mobility and, the ability for people to have a decent quality of life.
Yeah, and there you go, gang. It sounds as simple as that. It's not as simple as that. We spent an hour. I hope you've learned something. You can learn more by going to veinclinicsofhawaii.com. Dr. Juliff's, we can talk virtually. We can do everything that we need to be, and then you come in and you meet the staff, you'll be blown away. veinclinicsofhawaii.com. Have a terrific time, and if you got this swelling, you want to get it identified, that should be one of the steps along the road that you ought to be taking. So once again, thanks for listening. On behalf of Dr. Randall Juliff and the entire staff at Vein Clinics of Hawaii, I'm Mike Buck. We will see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.